Welcome, my dear students, to Game for PGs. It is a practical channel meant for gross and microscopy, but it has been expanded to other practical exercises both for undergraduates and postgraduates. I would like you people to kindly convey this message to your junior students. The job for today will be weight, FITE, FARACO, stain. In the last class, we had seen the PAS. Staining here, I thought was a very simple procedure, not much to talk. And then as I went and did a little bit of homework, I found that there are certain things which we shall understand and reproduce. Thanks to Dreams Time for this wonderful background of an ancient laboratory. The gentleman we are seeing on the screen is Gerard Hansen, in whose name the disease is now called Hansen's disease. It is no longer called leprosy, which is supposed to be a stigma. On the right side, I am finding carbonyl fusion being applied to the smears, and there is a heat fixation that is going on. So there is a hot method of staining, which means there is a cold method also. So you people should remember these two. In your bacteriology, you should have been doing this hot method for the acid-fast staining. Whereas here, you are not supposed to heat. So this is one procedure that is being followed. So please do remember, for the time being, there is a hot method, there is a cold method, and we are following the cold method. Now, what are we seeing on the screen? It is a picture of stigmatum. There are people over here, and then a Hansens patient is walking alone. He is being kept aloof. A very beautifully depicted picture by Cooper. And instantly you find that this particular person happens to be one of the pioneers in designing a stain for Deparaphernalizing. So this is of paramount importance, and I was having a lot of difficulty in picking up pictures of the great stalwarts who had contributed towards Hansen's disease. The structure of the Mycobacterium leprae. I am not taking a microbiology class, but this is of importance to us from the staining point of view. You find that the bacterium has got surface glycolipids, which again are consisting of mycotic acid, arabinidone lactone, and peptidoglycan. These three are there, 1, 2, and 3. This is followed by the lipid bilayer between two monomolecular layers of protein. So this is the structure of the leprabacillus. It is aerobic, rod-shaped. It has got parallel sides, and the ends of the bacterium is rounded, short and stout, unlike the tubercle bacilli, which is long and slender. It can develop a cigar bundle-like appearance or a fish in a stream appearance when the bacilli are adherent together. 1 to 8 microns long, 0.2 to 0.5 microns in width. So this is a structure that we shall be remembering. And coming to the panel of stains for the leprabacillus, you find carbonyl fuchsin by itself was used. Gram stain, PAS, acid-fast stain, the Zeal-Nielsen's classical method used for tubercle bacilli was done for leprabacillus also. Later on, for tissue sections, a lot of changes have been brought about by Ellis and Zabravarni. Modified bleaching method of the Zeal-Nielsen stain. FITE FARACO stain, as it is now classically called. Cooper's modification, who was the author of the picture that I showed first. And weight FITE's modification of their own stain. Like this, you find that there are panels and panels of staining methods Obviously, a lot of research has been done on the leprobacillus for a lot of reasons. Until today, we have not been able to eradicate leprosy. So this is the structure. I would like you people to kindly appreciate the rounded ends of the bacillus. Basic things first. So these are the basic steps in the acid-fast staining. You apply carbonyl fusion for a period of 30 seconds. Then there is a heating that is done. You find fumes of it evaporating. After some time, it is decolorized with acid alcohol. 15 to 20 seconds is the time that is given. It can vary. Ultimately, I find that the bacilli take up the stain. And it is counter-stained with another stain called the methylene blue. So you get a picture like this. The bacilli retain this and the other substances take up the methylene blue color. These are the basic steps of acid-fast staining. This is applicable to the leprobacillus also. Then why do we need a modification? Why do you need improved stains? The text is given here. This I would like you people to kindly by heart. The mycobacterial cell is composed of a waxy substance called mycolic acid. The cell wall contains mycolic acid. These are hydroxycarboxylic acids with these details. The property of the acid fastness is related to the length of the mycolic acid that is found. So you find that since leprobacillus contains it, the same conventional method will not be that effective. In fact, the stain is said to be lost after some time. Hence, an improvement is needed. The leprosy bacillus then is less acid and alcohol fast than the tubercle bacilli. What do you mean by the word fast? It can retain the staining that we are doing. Tubercle bacillus retains it well, whereas leprobacillus does not do so. That is why it is mentioned as less acid and alcohol fast. Therefore, the alcohol is removed from the hydrating and the dehydrating steps. 10% sulfuric acid is used as a decolorizer. There we are using 1% HCl. The sections are also deparaphernized using this combination. What is this combination? Peanut oil and xylene mixture. So we shall be seeing that. When you see the bacteria in a slide, there are different formats of them. Usually we do find solid bacilli with rounded ends, but sometimes they can be fragmented, particularly when the patient is on treatment or when there is a lepra reaction or when the bacilli die, you find that there is fragmentation. Also, in some cases, I find them to be only granular powdery material. So these three things we should have in mind. The structure when we are seeing under the microscope. I am interested in it only as a technician. And for reading the smears, I need a bacteriological index, density of the leprobacilli, a microbiological index of the live bacilli among the total. And there is a solid, fragmented, and granular percentage. You see the total and calculate the percentage. These are the three methods by which we will have to express. In the exam, they will definitely ask you what will be the grading. And before you utter the grading as such, please mention the indices. Bacteriological index, microbiological index, and the solid, fragmented, granular percentage. And this is the bacteriological index that has been developed by Ridley. Ridley and Joplin, another fantastic personalities who have dedicated their life. In fact, they have changed their classification n number of times. So these are some people we should always salute. Look at the grading over here from 1+ to 6+. And This is the value that you people get. I would like you people to kindly memorize. 1 to 10 bacilli in 100 fields, 1 to 10 in 10 fields, 1 to 10 in a single field, and 10 to 100 in an average field, 100 to 1000 in an average field, and then finally you find more than 1000 in a field, which is graded as 6+. Normally this we see in a histioid Hansens or in Lepromatous leprosy. So bacteriological index is one that we have mentioned earlier. So this is a table which we need not memorize. This is a set of clinical presentation and the lepromin test. On this side, I am finding the types of leprosy. The details are given over here. We shall not bother about it. Then, why am I presenting this particular slide? It is for one reason. In lepromin test, it is strongly positive for tuberculoid type of leprosy. The second fact is, in Lepromatous leprosy, there will be many bacilli and globi. Also, you find that they may be found in the nasal scrapings. This will have to be borne in mind. These two things alone. At one extreme, too many bacteria. At another extreme, a strong positive lepromin test. That much we shall remember. Nothing beyond it. Now, this is a slit skin that is being prepared. What is the anesthesia that is given? No anesthesia is required because it is an anesthetic patch itself or a hyposensitive patch. Therefore, after sterilization, there is a slit and the material obtained. The diagnosis is based on the clinical symptoms, which can be hypopigmentation, anesthesia, or a neural thickening. Slit skin smear, skin biopsy, nerve biopsy, and the lepromin test. These are the basic markers for diagnosis of leprosy. And in this, I am finding the conventional acid-fast stain and the recent modification of it. So, if you are technically superb, you will be able to see that there is a fine difference between these two pictures. Also, do observe that there are large vacuolated cells in the background which are harboring the bacilli, which are seen in clusters. Maybe they are called the globi. The question that we had asked earlier, why do you use peanut oil? I could have used xylene itself. Because of the high content of the mycolic acid. The bacilli is supposed to be acid fast. But after decolorization, you find it can be losing it. So this is prevented by means of the peanut oil. It acts somewhat as a cushion to preserve the mycolic acid. There is no disintegration of it. If it were to be by xylene alone, you find Mycobacterium leprae will be losing its acid fastness after the exposure. In 1938, FITE was a person who developed the vegetable oil and the chicken fat for the deparaphernizing. Later, this has been replaced by the peanut oil, which coats the bacterial wall, minimizing the decolorization. So you are likely to be asked this question. Why are you using the peanut oil? So this much explanation you people should give. It should be to preserve the bacterial wall with the mycolic acid. And the FITE stain, it uses a mixture of peanut oil and xylene in equal proportions, 50-50. This was the year when it was discovered. In 1970, another oil, canola oil, was also found. Peanut oil has got a high viscosity, and there is also another substitute called the mineral oil, which is used for various skin lotions. These are certain substances which can be used, but peanut oil is a classical answer that you people can give. And what is the ratio? 1:1, peanut oil and xylene. Now, these are the steps in the acid-fast staining or the FITE FARACO staining. I will just be reading it. Kindly follow me. Used for the microorganisms such as leprosy. And it is used to demonstrate Mycobacterium leprae. The principle is, as mentioned earlier, peanut oil is combined with xylene for deparaphernizing. There is a minimal exposure to the bacterial cell wall to the subsequent organic solvents. Therefore, it protects the precarious acid fastness of the organism. This is exactly the answer that you people should give. Neither am I nor you an expert in this, but the technician is. In fact, I have got some of the tips from the technician before taking this class. The control always must be used. It is a leprosy positive slide. The fixative is 10% formalin. What is 10% formalin is a different story. We shall see that under fixatives. So this is again the method, deparaffernizing it for a period of 10 minutes, change. You do it thrice. Drain the slides and blot off the excess oil. Rinse in distilled water until the slide appears clear. Xylene always, it is a clearing agent. The slide will be appearing clear. Carbalfuchsin is used for a period of 30 minutes at room temperature. Remember, the method that we are following is a cold method. No heating is done. Wash in tap water, acid alcohol is used, and finally, you counter stain it with methylene blue if you are going to do an acid fast stain. In the case of a FITE FARACO, this will be the modification that is done. Wash, blot and dry, dip in xylene and mount. This is another use of the xylene. It can be used as a clearing agent. It can be used for deparaffernizing. It can be used for mounting also. In fact, DPX is diestrin dibutyl phthalate xylene. The results are the Leprabacillus takes up a magenta color, nuclei in the background a blue color, and the red cells pale pink in color. So this is the way it is done. When the hot solutions are prepared, they should be done under the fume hood. Basic fusion by itself is a carcinogen. And you find that there is a mixture of xylene and the peanut oil that is used. You'll have to label it and preserve it. It can be stable for a period of nearly 1 year. All these are taken from WebPath, and you people can go to the references given over here. This is a sample of the mineral oil that is given over here, and this is the mineral oil. What are all the uses of it? There are multiple uses, 30 unexpected uses of the mineral oil, changing from dandruff to constipation. And I put the 31st one as deparaffernizing for the FITE stain. So this is again the method, and the counter stain is mentioned. The sampling, a slit skin, or sometimes the earlobe is used as an area of sampling. A staining is done. This is an ordinary acid fast stain, which is showing the pink color of the bacilli. Now, what are we seeing on the screen? It's a nerve abscess. Whether it is a median nerve or an ulnar nerve, one of the common presentations, that too in a tuberculoid leprosy, will be a nerve abscess. And what is being done is, the nerve is over here, there has been a perineural abscess, the contents are being drained. They are not purulent looking as in a staphylococcal infection, almost clear. This can be used as a sample for staining. And on this side, I am finding, say, some vacuolated cells, but otherwise I can appreciate a spindle-shaped contour, and there is a overlying skin. So these are again modifications of the histiocytes. Usually in the hand or the elbow, there is one variant called the histioid Hansens. which can be present. So this is the formula of the reagent. You people can go through it. I have put it purposely for a purpose. The reference has been FARACO in the year 1938, whose picture I struggled, I could not get it. I hope you people will be able to help me. The colors we have already mentioned. I will not be going into the details. Look at this one, the FITE method. There can be a routine acid-fast stain, or there can be a modification of it. This is a modification in which I am seeing. And the background can be by means of the methylene blue. Wisdom matters. I would like to recall an experience of ours. There was a lesion around the elbow with a nodular appearance. People were thinking of either a schwannoma or a neurofibroma or a histiocytic lesion. It happened in Jipmer several decades back. And when it was brought to the notice of Professor Veliath, he immediately asked for one acid-fast, rather a FITE FARACO stain. And when the stain was done, it was teeming with bacilli. And the spindle-shaped cells were supposed to be variants of the foamy macrophages you see in leprosy. It is called as histioid Hansens. Histioid means it resembles the histiocytes. There are other stains also which can be done. This is a PAS. It is not as convincing as the FITE FARACO stain, but still it is positive. The bacillary details are not very well brought out, but the positivity is PAS stain. Here again it is positive. Again the bacterial architecture is not well brought out. It is an Alcian blue stain. So when you people are asked about the various stains, you can mention PAS also, Alcian blue, but these should be last in your list, or you should be strong enough to defend your diagnosis. These are very well given in any of the text of histopathological techniques. Leprosy does not stop with it. There has been an immunostaining for the BCG antigens, which is shown over here, and also immunoelectron staining. It is an electron microscopic picture wherein there has been an immunostaining called as immunoelectron staining, and this has been provided by this company. Details are not there, but positivity is very much highlighted. There is yet another method called the multiplex PCR. So here you find it is positive, whereas towards the 11th, 12th, it is being negative, 13. So this is important for us. Multiplex PCR, polymerase chain reaction. And why so much of work is being done in the leprobacillus? Because of one simple reason. We are not able to grow the organism in culture. Were that possible, then we would have treated it and we would have found out various drugs which would have been highly effective. So much of staining would not have been required. But nowadays, it is being needed even for the tubercle bacilli. All of you people know that. Leprosy as such, or Hansens, you can imagine very much, no? You find that there is a lot of psychology behind it. It is not just the amputated digits because of self-inflicted damage, loss of sensation. But you find that there is something folding, something desperately holding one hand to the other. A kind of stigma and a helplessness, which is very classical of the Hansens disease. And I happen to trace this one, Joplin. So Ridley and Joplin, they are stalwarts who have done rather dedicated their lives, and there are enough number of these classifications and modifications which you people shall go to. Claims are huge by pathologists, our contributions so. I am purposely pausing here for a few seconds. Look at this one. What I am seeing behind is a hospital in Karigiri, close to Chengalpet district in Tamil Nadu. And the entire class of mine is dedicated to these people who are working there. Even if it is going to be a central government supported, how many of us will be willing to take up a job in Karigiri? Kindly answer this question. Otherwise, retain the entire class, do your best, and I do not want you people to get less than 80% marks if you are getting weight FITE FARACO as a special exercise. Thank you.